to Medico Important Simplified. So we are going to cover a very important topic in community medicine, TB as well as the TB programs in India. So any untreated one case of TB can cause around 10 to 15 new cases per year. Okay, so one untreated case of TB can cause around 10 to 15 new cases per year. Remember, when is the World TB Day? The World TB Day was on 24th March. And the theme for National TB program in 2022 was Invest in TB and Save Lives. The slogan of National TB Elimination Program is TB Hariga Dish Jitiga. So this is the National Tuberculosis Elimination Program logo, TB Mukt Bharat, where the slogan is TB Hariga Desh Jitiga. The new slogan for this year given is around for 2022 is TB Mukt Bharat. And TB notification in 2021 was 19.5 lakh and incidence of TB is around 188 cases per lakh. Now let's look at the epidemiological determinants. So the epidemiological determinants are, first we need to know what is the agent causing tuberculosis, Mycobacterium tuberculosis. So Mycobacterium tuberculosis is an obligate aerobe. Remember, it is an aerobe bacteria, obligate aerobe, and it is also facultative intracellular, and any acid fast stain, that is by Zeal-Nielsen stain method, due to mycolic acid, it is going to be acid fast. It will remain pink in color because of the mycolic acid content in the cell wall. Other acid fast stain bacilli are going to be Nocardia, Isospora and Mycobacterium lepra. Robert Koch discovered Mycobacterium. Very important finding. Robert Koch discovered Mycobacterium tuberculosis on 24th March. That is why it is celebrated as World TB Day. So atypical mycobacteria example is going to be Mycobacterium kansai, Mycobacterium scophulesium and Mycobacterium fortunatum. Host factors. So the age generally for TB is around 15 to 45 years. One of the main risk factor for tuberculosis is malnutrition or undernutrition is a very, very important risk factor. So coming to the social factors are poverty, malnutrition, overcrowding, unhygienic conditions. All these are risk factors for tuberculosis. Now let's look at the pathophysiology. First, we look at the primary TB. Primary TB means what? The bacilli is going to attack the hilar area of the lung. And the first lesion in pulmonary tuberculosis is Gons focus. So you know Gons focus, it is just between the lower border of the middle lobe and upper border of the lower lobe. Okay, that is where you going to get the Gons focus. Okay, so if this is the lung and this is the pleura, there is a subpleural region over here and this is your Gons focus. This is your Gons focus. Now, if there is involvement of lymph nodes along with Gons focus, it's going to be known as Gons complex. This Gons complex may calcify and form the Ranke's complex. Now, next, moving on to the next slide. Progressive primary tuberculosis. Now the TB bacilli may cause a local inflammatory reaction and it is usually seen in children or people with low immunity, whoever having low immunity, and may present with fever, chronic cough, pleuritis, pneumonia like illness, erythema nodosum, fictinellar conjunctivitis. Now let's see what is latent tuberculosis. So TB bacilli is going to be dormant in latent tuberculosis, seen in 2 to 4% of total primary TB cases. What is secondary TB or reactivation TB. So secondary tuberculosis or reactivation tuberculosis is under stressor, the TB bacilli gets reactivated and causes something known as cavitation. It causes cavitation in the lungs. Cavitation is a type of delayed, it's very important, delayed type 4 hypersensitivity reaction. So cavitation is an example for delayed type 4 hypersensitivity reaction. Cavitation is common in the upper part of the lungs. Why it is common in the upper part of the lungs? Because as ventilation is highest. Why it is common in upper part of the lungs? Because the ventilation is highest and the perfusion is lowest. That is, ventilation is highest. Ventilation is high in the upper lobe, okay, in the upper part of the lung. The ventilation is highest and the perfusion, okay, the perfusion is going to be lowest. Therefore, the ventilation quotient ratio is going to be very maximum. That is why the cavitation is very common in the upper part of the lung. TB bacilli may spread from the cavities through the bronchus and the person may spread tuberculosis. Approximately 40% of the Indian population have a primary TB infection. So we finished what is latent TB, what is secondary TB and primary TB. Now let's move on to the diagnostics in tuberculosis. So we are going to talk about the diagnostics in tuberculosis. First main important diagnostic investigation is chest X-ray. So in chest X-ray we can see for cavitations or any other non-sensitive investigation. Okay, it's a non-sensitive and a non-specific investigation. The next investigation is your sputum testing. Very important. It is done in diagnostic microscopic centers, DMC labs. Diagnostic microscopy centers. Okay, DMC labs, diagnostic microscopy centers. 2 sputum samples are taken. Very important. What are these 2 sputum samples? When should we take these samples? One is a spot sample. Spot sample means taking at the time the patient is coming. That time itself you are going to take a sample, that is known as spot sample. Another sample is an early morning sample. So these 2 samples are must to be collected in a TB case. Then all these going to be checked within 24 hours and a minimal 5 ml of sputum should be collected. This is also a previous MCQ. What is the minimum ml of sputum to be collected for a TB case? 5 ml. Minimal of 5 ml should be collected in a TB case for sputum. Now sputum should be a expectorated sputum. Okay, it should be of mucoid, purulent or mucopurulent. Now squamous epithelial cells. Remember, while collecting the sputum, the squamous epithelial cells should always be less than 10% in an expectorated sputum. So in any expectorated sputum, the squamous epithelial cells must always be less than 10% in an expectorated sputum. Now let's look at the types of sputum testing. So the types of sputum testing are first by a conventional microscopy, that is the Zeal-Nielsen method. So yeah, which is your Zeal-Nielsen method of testing. And then you can do by a LED microscope also, same Zeal-Nielsen staining. Fluorescence microscopy is the best test. Very important. The best one is going to be your fluorescence microscopy is the best one. Which one? What is the fluorescence microscopy stain? The stain is going to be auramine or rhodamine stain. Very important. So the best one is your fluorescence. Your fluorescence microscopy is the best for diagnosing tuberculosis, and the stain used is very important. Auramine or rhodamine. Auramine or rhodamine stain. That is your fluorescent microscopy stain you are using. Now let's look at the grading scale for bright fields. That is the Zeil-Nielsen and the fluorescent microscopy. So the grading scales in Zeil-Nielsen and fluorescence microscopy is, if you look at the bright field, see, if you look at this one, in especially in your fluorescence, okay, if you're seeing fluorescence where it's going to be around 400x magnification and one length is 40 fields, 0 acid phase bacilli per one length is a negative one. Around the most frequently asked is this one. Remember just bright field magnification. In bright field magnification, again negative is 0 acid phase bacilli per one length. So when do you say scanty? If it is 1 to 9 acid phase bacilli per one length or per 100 fields, then it's going to be scanty. And if it is 10 to 99 acid phase bacilli per one length or 100 fields, it is going to be plus 1. If it is 1 to 10 acid phase bacilli per one field, then it is plus 2. If it is more than 10 acid phase bacilli per one field, it is average, that is plus 3. So in short, let me tell about the grading. In a normal bright field microscopy, the acid phase bacilli Zeil-Nielsen method grading is, if it is 0 acid phase bacilli per field, okay, or 0 acid phase bacilli per length, one length is going to be 100 fields, okay, one length or 100 fields, it's going to be grade 0. It's going to be negative. It's negative. And if it is around 1 to 9, okay, so if it is 1 to 9 acid phase bacilli per 100 fields, then it is going to be grade 1. If it is 10 to 99 acid phase bacilli per 100 fields, it is grade 2. And if it is 1 to 10 acid phase bacilli per one field, then it is grade 3. I'm sorry guys, 1 to 9 is scanty. If 1 to 10, it is plus 2 and plus 3 is more than 10 acid phase bacilli per one field. Now 100 high power field in a slide is nothing but 100 high power field is nothing but 2 centimeter on the slide. Sputum test has always high sensitivity and a good specificity. Now let's look at the genotypic test, which is your rapid molecular test. Very important test is going to be your CB-NAT. So what does CB-NAT stands for? Cartridge based nucleic acid amplification test. Cartridge based nucleic acid amplification test. It is having high specificity as well as good sensitivity. It is a diagnostic and confirmatory test. Very important for diagnosis and confirmation. It's going to be a cartridge based nucleic acid amplification test. So the biggest advantage of CB-NAT is the turnover time is just going to be around 90 minutes. So within 1.5 hours, you're going to get the results. That is why this is the best one. Rifampicin status of a person can always be known under CBNAT. So by just CBNAT, whether the bacilli is rifampicin sensitive or resistant can also be known. Now, TrueNAT. So what is TrueNAT? TrueNAT is a Indianized version of CBNAT. So in India we do not use CBNAT, but we use something known as TrueNAT. It is the Indianized version of CBNAT, and it is less expensive, and it is approved by NTEP, and the turnover time is more better. It's just 1 hour. There we study 90 minutes. Here it is 1 hour. This is your gene expert machine. This is your gene expert machine for CBNAT. This machine is your gene expert machine for CBNAT. Next, moving on to the line probe assay. So line probe assay is basically a molecular test. What are the advantages of line probe assay? The report is available within 2 to 3 days. The resistance pattern can be known. You have something known as the first line probe assay and second line probe assay. In first line probe assay, isoniazid resistance can be detected. Isoniazid resistance. In second line probe assay, resistance to fluoroquinolones as well as the second line injectable drugs can be detected. So if you look at the drug resistance in isoniazid, let's look at the target region, the genes. So there are certain genes, okay, which is going to be being responsible for the resistance. So for isoniazid resistance, what is the gene? For pyrazinamide, what is the gene? For fluoroquinolone, what is the gene? So for this is for isoniazid, this is for pyrazinamide, this is for fluoroquinolone, and then you're going to look for amikacin, kanamycin and capreomycin. So the main genes are for isoniazid, it's going to be INHA promoter and CATG gene. Okay, INHA promoter gene as well as your CATG gene. Remember, CATG is very important. For pyrazinamide, it's just going to be a INH promoter gene. Okay, inhibitor A gene. For fluoroquinolone, it's going to be GAIR A gene, and GAIR B gene. For amikacin, kanamycin and capreomycin, it's going to be our RRS gene and EIS promoter gene. Just remember, isoniazid, it's INH A promoter gene and CATG gene. For pyrazinamide, INH promoter gene. For fluoroquinolone, it's GAIR A and GAIR B gene. So the most common resistance always noted or always seen is going to be your isoniazid resistance. So let's look at the other phenotypic methods. That is known as your backtech method. Very important. It's a culture method. So backtech. What is this backtech method? Backtech method is a C14 labeled palmitic acid immunoassay. It gives information about the CO2 emission by the live bacilli. So backtech gene or the backtech method gives information about the CO2 emission. Okay, CO2 emission by the bacilli, by the live bacilli. And it is used for drug sensitivity testing and research. It is a second line investigation. After backtech, the very famous method is MJIT method. So what is this MJIT method? So it also gives information about oxygen consumption by the live bacilli. We studied that backtech was giving information about the CO2 emission by the live bacilli. See, it is an aerobe. Aerobe means it's going to consume oxygen and it's going to be releasing carbon dioxide like us. So therefore the backtech will be detecting the CO2 emission by the live bacilli, and the MJIT will be detecting the oxygen consumption by the live bacilli. Oxygen consumed by the live bacilli. So the metabolism rate of the bacilli is known by this method. It is more specific. It is used for drug sensitivity testing and research. It is used as a second line investigation. So what are the culture methods? So moving on to the culture methods. The culture methods are, First is going to be your egg based solid media. Okay, so the first method is going to be your egg based solid media, and then agar based, and then liquid culture. So egg based or solid media methods are going to be your Lowenstein-Jensen media, LJ method, very famous media. It is the most widely used media, Lowenstein-Jensen media, LJ method. The duration of time that it takes place is, so what is the duration of time it takes place? It takes place around 8 to 10 weeks. Remember, the duration for LJ media is 8 to 10 weeks. 8 to 10 weeks. So it's very long duration, right? You can't just wait for 8 to 10 weeks to treat a TB patient. So therefore, it is started earlier itself. Agar based. Agar based is not used in NTEP. Liquid culture, it is using Bactec or MGIT method. Okay, any Bactec or MGIT method. Bactec or MGIT method. There is this Kitchener media or famous Middlebrook media is famous. So LJ media, and it is going to be not use. Okay, so agar based, and liquid media is Bactec or MGIT method, and Middlebrook method also takes around 1 to 2 weeks. So because Middlebrook method is used in is very less duration, just 1 to 2 weeks. Therefore, it is used in NTEP. Remember, Middlebrook method is used in NTEP. Now let's look at some serological tests. IGRA. IGRA stands for Immune Gamma Release Assay. So what is IGRA? Immune Gamma Release Assay. It is not used for diagnosis in India. It's just used to diagnose latent TB in some countries. Then you have antigen antibody tests and quantiferon test, which gives information about TB infection and not the disease. And it's banned in India, so no need to remember, guys. So remember GIST test, very important one. That is your tuberculin skin test. So tuberculin skin test is otherwise known as always favorite MCQ. What are the other names for tuberculin test, skin test? So tuberculin skin test is otherwise known as Perquet test, or your Montauk's test. So Montauk's test, it's the tuberculin skin test. The other important name to be remembered is your Perquet test. So Perquet test. So 1 unit of PPD, that is your purified protein derivative. 1 international unit of purified protein derivative. What strain? RT23 with tween 80 is used. Remember, very important, 1 international unit of purified protein derivative. What strain? RT23 with tween 80. Tween 80 is used. So it is not used for TB diagnosis in adults, but has some utility in diagnosis of TB in children. Test is going to be read after 48 hours. Very important. After 48 hours, where there is a wheal or a flare reaction. The average time is generally 72 hours. Now, this table is very important. So, if at all the wheal reaction is more than 5 mm, it is positive in case of HIV, severe immunosuppression, close contacts of TB, and history of prior TB. If the reaction is more than 10 mm, then it is definitely positive in case of immigrants, age less than 4 years, adolescents with exposure from high risk groups. If more than 15 mm, there is no risk factor. Okay. So 2-step tuberculin skin test. On repeated tuberculin skin test, sensitivity decreases and there will be no response to tuberculin skin test. And if the tuberculin skin test is negatively initially, you need to repeat this test after 3 weeks. On repeat testing, if test is positive, consider tuberculin skin test positive. This is not very important. Now let's move on to the diagnosis of NTEP. So diagnosis of NTEP is, there is going to be a sputum for acid fast bacilli and chest ray positive. So these are the two criteria. And your middle brook, okay, and then multi-tuberculosis expert, gene expert, MTB and rifampicin, CBNAT is going to be done. And your PCR system, TrueNAT is done. And line probe assay, first line probe assay. So what is the resistance gene for R resistant, rifampicin resistance? The gene is RPOB gene. Remember, for rifampicin resistance, the gene is going to be RPO. Rifampicin resistance, the gene is going to be RPOB gene. Remember, RPOB gene. And in CATG gene and INHA promoter gene for isoniazid resistance. So for rifampicin, it's going to be RPOB gene. Second line probe assay genes are GAIR A and GAIR B for fluoroquinolone resistance. And RRS and EIS is for the other second line injectable drugs like kanamycin, amikacin, all of those drugs. Now moving on to the Bactec MJIT 960. Bactec MJIT 960 is an automated liquid culture system. It is gold standard if other TB bacilli cannot be identified by other methods. Okay, so always liquid culture is considered to be a gold standard method for diagnosing TB. And this is the laboratory turnaround time. Solid culture is your remember, solid culture is going to be your Lowenstein-Jensen medium. So the time is around, you need at least 4 to 8 weeks for the samples. Then automated liquid culture, Bactec or MJIT 960 TB system. So it's going to take around 2 weeks. And then you have your line probe assay, detecting for drug resistance. It takes around 1 to 3 days. Your CBNAT takes around 2 hours. Very important, just 2 hours. Your TrueNAT takes time around just 1 hour. Your immunochromatographic assay takes around 15 minutes. But because you need to perform it on solid and liquid culture, it takes more time. Now let's move on to the very important all-time short note. What is NTEP, or even long note? Short note or long note. Okay. So NTEP, that is National Tuberculosis Elimination Program. NTEP stands for National Tuberculosis Elimination Program. So in 1962, around National TB program was started. In 1997, you got your RNTCP, that is Revised National TB Control Program. In 1997, you have the DOTS, which was started, very famous. DOTS stands for Directly Observed Treatment Short Course. Directly Observed Treatment Short Course. Around 2020, so NTEP, National TB Elimination Program, NTEP was started in the year 2020. So this RNTCP from 1997 was revised to NTEP in the year 2020. So this is the figure of National Tuberculosis Elimination Program. So as per Indian TB report 2020, TB incidence is 188 per lakh, it seems. It's quite high. So the multi-drug resistant cases are 4 per lakh. And the extensively drug resistance 1 per lakh. So the median age is going to be for tuberculosis is 15 to 45 years. The incidence is more common in males as compared to females. So yeah, so this is the incidence of TB. So 15 to 45 years, around 15 to 45 years, the incidence for TB is more. This area, the TB is going to be more. World TB Day is observed in 24th March, as we already studied. The theme for 2022 is Invest to End TB and Save Life. Targets, you have NTB target. What is NTB? NTB means to reduce the TB death as well as to reduce the TB incidence. So as per the Sustainable Developmental Goals, it was started on 2015 and will be placed till 2030. So Sustainable Development Goal targets to end TB was by 2030. So by 2030 is the NTB strategy given by Sustainable Developmental Goals. With a reduction in death by 90% and death reduction should be 90%, incidence reduction should be 80%, while the WHO targets to end TB is going to be by 2030. See, first this is your Sustainable Development Goal. Your Sustainable Development Goal was started around 2015. Okay, and it gave NTB to be ended by 2030. And what it says is the death should be reduced by 90% and the incidence of TB should be reduced by 80%. So this must be attained by the year 2030 by Sustainable Developmental Goals. But what does the WHO say? As per the WHO is going to be ending TB. So the plans to end TB by 2035 with the death by 95%, but the death should be reduced by 95% and the incidence should be reduced by 90%. See, the year is more, so the target is also more. So Sustainable Developmental Goal, it started in 2015. It plans to end TB by 2030. So reduces death by 90% and incidence by 80%. Whereas the WHO plans to end TB by 2035. The death is going to be reduced by 95% and incidence to be reduced by 90%. So NTEP India targets to end TB in 2025. So in India, as per the National Tuberculosis Elimination Program, it plans to end TB by 2025 by reducing the mortality less than 90% and incidence less than 80%. Exactly like this Sustainable Developmental Goal, death by 90% reduction and mortality, incidence by 80% reduction, and the target date is 2025. Now let's look at the National Strategic Plan. So what is the National Strategic Plan that is for ending TB given? So National Strategic Plan for ending TB was given in the year 2017 to 2025. So nationwide coverage of universal drug susceptibility testing, that is the CBNAT universalization. So there is going to be universalization of CBNAT by, and the second one is by promoting two newer drugs, which is your bedaquiline, BDQ, bedaquiline and dilamanid. So bedaquiline and dilamanid are the two newer drugs for promoting. Okay, and then third one is introduction of TrueNAT. What is TrueNAT? As I already tell, it is the Indian version of CBNAT. It is having a shorter and a longer oral MDR-TB regimen. Okay, a shorter as well as a longer oral MDR-TB regimen is going to be promoted. So, National Strategic Plan for Ending TB from 2017 to 2015 says just four things. First is universalization of CBNAT using TrueNAT, which is the Indian version of CBNAT. Then promoting two newer drugs, that is bedaquiline and delamanid, and then shorter and long oral MDR-TB regimen. So this is the National Strategic Plan for India. See the National Strategic Plan 2000 to 25. Universal drug susceptibility testing is a national policy. Very important. Universal drug susceptibility testing by CBNAT universalization. Introduction of newer drugs, bedaquiline and delamanid. CBNAT, that is gene expert, is introduced. Let's look at some very favorite even Viva questions, these definitions. Let's look at some definitions. First is what is presumptive TB case? So what do you mean by presumptive TB case? So any person with complaints of cough or fever, okay, especially evening rise of temperature and cough, or night sweats for a duration of more than 2 weeks, plus or minus significant weight loss, is a presumptive TB case. So when do we say is a presumptive TB case? Any person with complaints of cough, evening rise of temperature, night sweats, or for a duration of more than or equal to 2 weeks, plus or minus significant weight loss, is a presumptive TB case. So drug sensitive tuberculosis are the ones which are sensitive to rifampicin and isoniazid. And drug resistant tuberculosis is resistance to any other drug. Monodrug resistant tuberculosis is only to isoniazid resistance. Multidrug resistant tuberculosis, always asked. So what is multidrug resistant tuberculosis? Resistance to at least isoniazid and rifampicin. What is polydrug resistant tuberculosis? Polydrug means any two drug resistant, not including isoniazid and rifampicin simultaneously. So there are any other two drug resistant, okay. The tuberculosis is resistant to any two drugs, but except for isoniazid and rifampicin is polydrug resistant tuberculosis. What is extensively drug resistant tuberculosis? So extensively drug resistant tuberculosis means resistance to isoniazid, resistance to rifampicin, plus any fluoroquinolones, and any other group A drug. So what do you mean by group A drug? That is bedaquiline and linezolid. So what do you mean by XDR-TB? Extensively drug resistant tuberculosis is tuberculosis resistance to isoniazid, rifampicin, plus fluoroquinolones and any group A drug. Group A drug means bedaquiline and linezolid. So what is pre-XDR? Pre-extensively drug resistant tuberculosis. Pre means isoniazid plus rifampicin and any fluoroquinolone. That is pre-XDR TB. So ideal XDR TB is isoniazid resistance, rifampicin resistance, fluoroquinolone resistance, and any group A drug, which is bedaquiline and linezolid. So if you look at the group A drug, we are going to drug the anti-TB. Okay, anti-tuberculosis drugs are going to be done by grouping. Okay, and why we are doing this grouping? For designing a longer MDR-TB regimen. So the first group, let's look at the first group, group A. So group A consists of 3 medicines basically. It consists of 3 medicines. First one is your levofloxacin or your moxifloxacin. First is your levofloxacin or moxifloxacin. The second one is your bedaquiline, and the third drug is your linezolid. So what are your group A drugs? Levofloxacin or moxifloxacin. Second one is going to be your bedaquiline, and third one is your linezolid. Levoflox, moxiflox, bedaquiline, linezolid. So what do you mean by group B drugs? So group B drugs, you need to add one or both medicine, okay? First, group B drugs include the clofazimine, cyclosporine or terizidone. CS stands for cyclosporine. CFZ stands for clofazimine. So group B drugs is your clofazimine, your cyclosporine, as well as your terizidone. Remember, group B are again 3 drugs: clofazimine, cyclosporine, terizidone. And what is your group C drugs? Your group C drugs is you need to add to complete the regimen, and when medicines from group A and B cannot be used. So whenever group A medicines and group B medicines cannot be used, so group C medicines can be added. Okay. Now E for ethambutol, DIM for delamanid, Z for pyrazinamide, and then you have your imipenem, cilastatin or meropenem, and then your amikacin or streptomycin, and then ethionamide, prothionamide, and PAS. What is PAS? This is something new. Okay, new drug. So P amino salicylic acid. So PAS stands for para amino salicylic acid. So just para amino salicylic acid is a group C drug. Okay, so remember what are the drugs in group C? Group C drugs are ethambutol, delamanid, pyrazinamide, imipenem or meropenem, amikacin or streptomycin, ethionamide, prothionamide, para amino salicylic acid, PAS. So these 7 drugs are there, okay, in group C. Now let's move on to presumptive MDR. So what do you mean by presumptive MDR? So presumptive MDR case means anti-tubercular therapy for more than 1 month and default for more than 1 month. That is, there is lost to follow up. So it is a lost to follow up case. Currently on anti-tubercular therapy, poor response, that is no clinical improvement or sputum positive at 3rd or 5th month of follow-up. Okay, so there is a poor response. Any contact of MDR case, any contact of multi-drug resistant case, okay, any contact of MDR case. And what do you mean by recurrent TB? It is cured after ATT. Okay, so whenever tuberculosis, the patient is cured, okay, after giving anti-tubercular therapy, but now microbiologically confirmed sputum is going to be positive. So already the patient had TB, was cured by ATT, but when you're taking now, the sample is going to be positive. So that is a case of recurrent TB. Now what do you mean by relapse of TB? Relapse of TB is no longer used, okay, terminology. That is why relapse of TB we are not using this term. Now we are using is recurrent TB. So remember, recurrent TB is the term used, recurrent TB. So now let's move on. On ATT, poor response, no comorbidity. It's non or poor response to the first line therapy. ATT for more than 1 month and lost to follow up. Microbiologically confirmed TB. So the treatment is going to be after lost to follow up. So presumed MDR TB patient and contact of MDR TB patient or children living with HIV or with history of TB death in the household. Cured after ATT, now microbiologically confirmed relapse. All this is presumptive MDR. So let's look at a very important question. How are you going to do the diagnosis of TB? This is a important short note they ask in exams, so pay attention. Presumptive TB case, we already studied that is 2 sputum test positive plus NAT, CB-NAT plus your chest X-ray. So NAT could be either CB-NAT. Why do we say shortly NAT is? It could be either a CB-NAT or it could be either a true NAT, that is Indian version. So sputum test is very highly sensitive and CB-NAT is highly specific and therefore it's very preferred. If at all the sputum test and your NAT are going to be negative but the chest X-ray is normal, then you need to rule out the TB and you need to refer. So everything is, there's no there's no positive finding at all. Then you need to rule out TB and refer. If the sputum test is positive and the NAT is also positive, then it is known as microbiologically confirmed tuberculosis case. So when do you say microbiologically confirmed TB case? Sputum is positive, NAT is positive. Now when do you say it as a presumptive TB? So a presumptive TB, you need to look for the microscopy, you need to do the NAT, you need to do the chest X-ray. And suppose after doing this, rifampicin sensitive TB and you get a result as rifampicin resistant TB. So what are you going to do with rifampicin sensitive tuberculosis case? At health facility, a drug sensitive TB regimen should be given. So if it is rifampicin sensitive, then you need to give a drug sensitive TB regimen like isoniazid rifampicin and you need to send to treatment supporter and screen contacts of TB. If at all rifampicin resistant TB, then you do a first line probe assay and first line or second line probe assay, and depending on the results you need to look whether it's a mono or poly drug resistant, rifampicin resistant TB, MDR TB, pre-XDR TB, polydrug resistant TB, XDR TB. All of this can be detected by your first or second line probe assay. Now let's look at certain drug regimens. So if it is a case of drug sensitive TB, then you can give the normal fixed dose combination. So what is this fixed dose combination? We will give it in 2 phases. First 2 months is going to be your intensive phase, and then the next 4 months is going to be your continuation phase. So in the first 2 months intensive phase, you will be giving HRZE regimen. What H stands for isoniazid, R for rifampicin, Z for pyrazinamide and E for ethambutol. This is your fixed dose combination. Given daily. It's given daily, and in continuation phase you just give only HRE. That is, you do not give pyrazinamide. Pyrazinamide you won't give. HRZE is intensive phase and HR is E. You give only isoniazid, rifampicin and ethambutol during the continuation phase. Suppose it is a isoniazid resistant TB. Okay, it is a mono. Okay, high isoniazid resistant mono resistant TB or a polydrug resistant. There is no something like no such as intensive or continuation phase. For a polydrug resistant TB or a isoniazid mono resistant TB, there's no phase. Okay, you're going to give for 6 months. You're just going to give HRZT. No. So you have something known as shorter oral bedaquiline regime used for shorter multi-drug resistant and longer multi-drug or extensively drug resistant TB regime. So what is this shorter? Shorter means for 4 to 6 months it's going to be your intensive phase. CHOP-C is the mnemonic, C for clofazimine, high H for high dose isoniazid, and O for levofloxacin, B for bedaquiline, Z for pyrazinamide, E for ethambutol, and E for ethionamide. Remember, bedaquiline is always given for 6 months. Okay, so bedaquiline is always bedaquiline is always given for 6 months. And then you have your continuation phase for around 5 months. Course is the mnemonic, clofazimine, levofloxacin, pyrazinamide, and ethambutol. CHOP-C and course. And then longer multi-drug resistant TB regime is around it's a longer duration, around 18 to 20 months you are going to give this regime. So the mnemonic is L2, C2 and bedaquiline. Okay. So L for levofloxacin and linezolid, C for clofazimine and cyclosporine, and B for bedaquiline. So this is your longer MDR TB regimen. So L2 levofloxacin, linezolid, C2 for clofazimine and cyclosporine, and then bedaquiline. Remember pyridoxine. Okay, so pyridoxine is given to all the drug resistant TB patients as per the weight band. Remember always pyridoxine. Okay, pyridoxine vitamin B12 is given to all the drug resistant TB patients. Isoniazid, rifampicin, pyrazinamide, ethambutol, and levofloxacin. Okay, let's look at the patient. Patient started on TB treatment becomes 50 to 80% non-infectious within the first 48 hours, taking rifampicin, and more than 95% non-infectious by around 2 weeks. Now, shorter oral bedaquiline regime, otherwise known as the shorter multi-drug resistant regime, as we already told, CHOP-C, clofazimine, high dose isoniazid, levofloxacin, bedaquiline, pyrazinamide, ethambutol, and ethionamide. So all of this is going to be started till the 4 months. Okay, it start till 4 months. Bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose isoniazid, ethionamide, and the 5th and 6th month, 6 months always bedaquiline will be given along with levofloxacin, clofazimine, pyrazinamide, ethambutol, and 7th and 9th month no need bedaquiline. 7th and 9th month you can continue with only these drugs, levofloxacin, clofazimine, pyrazinamide, and ethambutol. Now let's look at what is fixed dose combination. So what do you mean by fixed dose combination? Fixed dose combination dosage chart is mainly given for pulmonary drug sensitive TB, okay, for pulmonary drug sensitive tuberculosis, and it has 5 weight bands for adults. So very important, what are the weight bands of tuberculosis drugs? So this is your fixed dose combination. So always remember this is your weight band drugs. Okay, and one fixed dose combination contains one fixed dose combination contains isoniazid 75 mg, rifampicin 150 mg, pyrazinamide 400 mg, ethambutol 275 mg. Very, very important. So how much is isoniazid? Isoniazid is going to be around 75 mg. How much is rifampicin? Is going to be 150, just the double. Rifampicin is 150 mg. Paracetamide is how much? 400 mg. And ethambutol is how much? 275 mg. Remember these values: 75, 150, 400, 275. So in the intensive phase, that is 2 months of HRZT regimen is given. That means 2 months of HRZT means how many doses? 50. 4 drugs. 4 drugs for 56 doses are given. In the continuation phase, 4 months of HRE alone is given. That is 112 doses are given. So intensive phase 2 months, continuation phase 4 months, 56 dose and 112 doses. Now let's look at the pulmonary drug sensitive TB adult weight bands. So you have intensive phase, continuation phase. So in intensive phase, the number of fixed dose combination tablets for 25 to 34 kg will be 2. For 35 to 49 kg, so every 9 kg it's going to increase. 25 to 34, so every 9 kg, so 25 to 34, or you can keep it as every 10 kg it's going to increase. So 25 to 34 is 2 tablets, 35 to 49, 35 to 49 is going to be 3 tablets, 50 to 64 is going to be 4 tablets, 65 to 75 is 5 tablets, more than 75 kg is 6 tablets, 25 to 34 kg is 2 tablets, 35 to 49 kg is 3 tablets, 50 to 64 kg is 4 tablets, 65 to 75 kg is 5 tablets, and more than 75 kg is 6 tablets. So the number of strips, totally 56 doses. 56 doses, the number of strips is going to be 4 strips, 6, 8, 10, 12, respectively. And in continuation phase, same. Always 25 to 32 is 2 tablets. So number of strips will be double, around 8. 35 to 49 is 3 tablets. The number of strips will be double, 12. And 50 to 60, 4 tablets. So it's going to be double, 16. 65 to 75, 5 tablets. But the strips will be 20. More than 75 is 6 tablets. Just 2 tables, right? 4, 6, 8, 10, 12 are these number of strips in intensive phase, because it's for 2 months. So one fixed dose combination HRZT consists of 75 mg, 150, 400 and 270 mg respectively per tablet. And HRE consists of 75, 150 and 275. No pyrazinamide. 75, 150, 275 mg respectively per tablet. So fixed dose combination dosage chart for pulmonary drug sensitive TB. So fixed FTC, fixed dose combination dosage chart for pulmonary drug sensitive TB has around 6 weight bands for children. It has around 6 weight bands for children. So one fixed dose combination contains how much? 6 weight bands for children. So very important, what we study, this is for adult dosage. This is for adult. In case of children, it's all going to be like around half. See how much in adult was isoniazid? 75. But in children, isoniazid will be 50 mg. It will be 50 mg. Remember, ethambutol is very toxic to children. So ethambutol usually, ethambutol will be always given separately. Remember, in children, ethambutol is given separately. So the fixed dose combination contains only of HRZ. one fixed dose combination only has HRZ, and ethambutol will be coming separately. H is going to be 50, isoniazid will be 50 milligram. Rifampicin will be how much? Just half of the adult dose. In adult it was 150. So in half is going to be 75 milligram. And then pyrazinamide, what was the adult dose? 400, relatively less, right? So half will be around 150. So it's less than half. So pyrazinamide will be around 150 mg in children. So in children, isoniazid is 50 milligram, rifampicin is 75 milligram, pyrazinamide is 150 milligram. Ethambutol is given separately. Ethambutol, what is the drug of dosage? It's going to be 100 milligram. So in adult, how much was ethambutol? Ethambutol we were giving 275 milligram, but in children it is 100 milligram. So in the intensive phase, that is 2 months of HRZ is going to be given, and ethambutol is given separately. So again 56 doses are given. So in continuation phase, 4 months of HRE alone, right? HR is given separately and ethambutol is given separately. Always remember, for children, ethambutol will not come in the fixed dose combination tablet. We need to give separately 100 mg of ethambutol. So totally around 112 doses are going to be given. Now let's look at the treatment regimen, daily fixed dose regimen for children less than 18 years. So the weight category will be 4 to 7 kg, 8 to 11 kg, 12 to 15 kg, 25 to 29 kg and 30 to 39 kg. So in intensive phase, isoniazid, rifampicin, pyrazinamide. So there are 3 fixed dose combination, 50, 75 and 150 respectively. Ethambutol is given separately, that is 100 milligram. So all of these tablets, the number of tablets will be respectively 1 and 1, 2 and 2, 3 and 3, 4 and 4. Okay, similar like and 56 doses will be given totally during the intensive phase. And 3 fixed dose combination, number of strips and tablets are given. So this is not much in detail, but just remember these basics, that there is a weight band for children also. In case of continuation phase, again HRE alone will be given, but HR is going to be given separately, 50 and 75 milligram per tablet, and ethambutol is 100 milligram per tablet. So what is the dose? 50, 75. Pyrazinamide is going to be 150, ethambutol is going to be 100. And dosage of shorter oral bedaquiline. So what is the dosage of shorter oral bedaquiline? Containing MDR or rifampicin resistant TB regimen drugs for adults. This is for adults. There is 4 weight bands. Okay, in case of adults. So high dose isoniazid, ethambutol, pyrazinamide. So these are the adult doses for, this is the shorter oral bedaquiline containing drugs. Okay, 300, 600, 900, 400. Ethambutol is 400, then 800, 1200, 1600 respectively. So the weight band is 16 to 29 kg, 30 to 45 kg, 46 to 70 kg, more than 70 kg. Levofloxacin, and look at the bedaquiline. Bedaquiline dosage is very important. So week 0 to 2 weeks. So bedaquiline 400 milligram is given daily. And from 3 to 24 weeks, bedaquiline 200 milligram 3 times per week is given. Okay, very important. So first 2 weeks, how are we giving bedaquiline? Bedaquiline is given 400 milligram daily. We are going to give. whereas the next 3 to 24 weeks, bedaquiline is given 200 milligram and is just given 3 times per week. Okay, now let's move on to the next important short note. Very favorite question, pregnancy and TB. So pregnancy and TB is an important question. So bedaquiline, what we need to remember very important is bedaquiline. Okay, bedaquiline is going to be contraindicated in pregnancy and pregnant mother is advised for MTP. Okay, always remember bedaquiline you should not give in pregnancy. It's always contraindicated in pregnancy. However, it is still given because TB is a public health disease, but generally bedaquiline is contraindicated in pregnancy otherwise. Now duration of the pregnancy you need to see. If there is a pregnant woman, you need to look for the duration of the pregnancy first. So see whether the duration is less than 20 weeks or it is more than 20 weeks. So if the duration is less than 20 weeks, you need to advise for MTP, medical termination of pregnancy. So MTP is going to be advised and MTP will be done. Okay, MTP will be done, and after MTP is done, you need to start or you need to continue the shorter or longer oral bedaquiline containing MDR or rifampicin resistant TB regimen. Okay, so you need to look for the duration of pregnancy. If less than 20 weeks, advise MTP. After MTP is done, what you need to do? You need to start or continue shorter or longer oral bedaquiline containing MDR or rifampicin resistant TB regimen. Now, if at all the duration is more than 20 weeks, it has crossed 20 weeks. Okay, you need to see if the patient is unwilling for medical termination of pregnancy. So, if the patient is also unwilling for medical termination of pregnancy, you need to look if the duration is more than 32 weeks or the duration is less than 32 weeks. If the duration is more than 32 weeks, what will you do? There is going to be a consultative decision between the obstetrician and the physician. And then you need to start or continue the longer oral bedaquiline containing MDR or XDR TB regimen. If less than 32 weeks also, you need to do the same. More than 32 weeks also is the same. What is BPAL regimen? BPAL regimen means bedaquiline, pretomanid, okay, bedaquiline, pretomanid, linazolid regimen. So B for bedaquiline, PA for pretomanid, L for linazolid regimen. So this BPAL regimen was advocated by WHO under operational research and taken up by few districts in India under NTEP. It was given if there is fluoroquinolone resistance or no exposure or less than 2 weeks exposure to bedaquiline or linezolid. So what is the dosage of bedaquiline, pretomanid, linezolid regimen? First, pretomanid is going to be 200 milligram once daily for 26 weeks. Bedaquiline is going to be 400 milligram once daily for 2 weeks. And then 200 milligram 3 times a week for 24 weeks. Linezolid is going to be 1200 milligram once daily for 24 weeks. So these are the respective doses. Inclusion criteria for bedaquiline or delamanid: patient should be aged more than 6 years, having multi-drug resistance or rifampicin resistant TB. They must be definitely non-pregnant female because bedaquiline is contraindicated in pregnancy. Patient with controlled stable arrhythmia, okay, or a no cardiac disease. So if at all arrhythmia, the patient must be controlled and stable, and no cardiac diseases must be there. So what is the exclusion criteria for bedaquiline and delamidine? So the exclusion criteria for bedaquiline as well as delamidine is pregnancy. It is contraindicated. As well as lactating mother also, you should not give bedaquiline or delamidine. Any kind of cardiac arrhythmia or conduction abnormality and prolonged QT, you shouldn't give. Okay. History of additional risk factors, especially torsades de pointes. Example, heart failure, hypokalemia, family history of long QT syndrome. Now let's look at the side effects of newer drugs. So what is the side effect of linezolid? Side effects are anemia, thrombocytopenia, peripheral neuritis and optic neuritis. Optic neuritis, peripheral neuritis, anemia and thrombocytopenia. Cycloserine, seizure disorder, severe depression. Clofazimine, dark brown discoloration of the skin. So what is the side effect for clofazimine? Dark brown discoloration of skin. Bedaquiline, side effect is electrolyte imbalance, cardiac failure and precipitation of arrhythmia. The pre-treatment evaluation for MDR or rifampicin resistant TB patients is, so what are the pre-treatment evaluation, guys? So complete blood count should be done for hemoglobin, TLC, DLC and platelet count, and blood urea and serum creatinine must be done. Then urine pregnancy test kit should be done in a women of reproductive age group, and liver function tests can be done. Thyroid stimulating hormone levels to be assessing the thyroid function. TSH levels alone are usually sufficient to assess the thyroid function of the patient. And then urine examination, routine urine examination, ECG, okay, especially if on moxifloxacin, bedaquiline, clofazimine and delamidine. Audiometry, okay, audiometry for only on injectable drugs, okay, because streptomycin, all these are ototoxic drugs, right? So audiometry can be done. Serum electrolytes like sodium, potassium, magnesium, calcium. Serum protein like albumin, globulin and total proteins. Ophthalmologist opinion, psychiatric opinion. All these can be done for the pre-treatment evaluation of MD. Now let's move on to NTEP new strategies, the organization and evaluation. As I already told, March 24 is the World TB Day. So you need to know what do you mean by case finding. Okay, so there is basically in NTEP program there is a case finding for finding new pulmonary TB cases, right? And this case finding is divided as passive case finding, intensified case finding, active case finding. So what is passive case finding? What is intensified case finding? What is active case finding? Passive case finding means patient with symptoms of TB will voluntarily seek the health care. So they will voluntarily seek the health care. That is passive case finding. So in passive case finding, the patients who are having symptoms of TB will be coming to the health care and voluntarily be seeking the health care. That is passive. In case of intensified case finding, this is a provider initiated screening of outpatient clinic or hospital attendees for symptoms of TB. So all the hospital attendees, okay, or any outpatient clinic attendees, all the people, basically the healthcare workers, they will be screened for symptoms of TB. So screening of outpatient clinic or hospital attendees is going to be coming under intensified case finding. Next is your active case finding. Active means what? We are actively screening for the TB patients among population at higher risk of TB in the community. So all the population which is having a higher risk of TB in the community, we will be actively searching for TB patients among that population. That actively searching of TB patients is known as active case finding. Now in passive case finding, the medical officer follows diagnostic algorithm for evaluating TB patients. So here in passive, the patients are voluntarily coming to the healthcare and seeking, right? So therefore the medical officer will be following a particular diagnostic algorithm what we studied earlier. In case of intensified case finding, TB screening for patients attending health facilities with comorbidities will be there. So TB screening for patients attending health facilities with comorbidities is going to be there. Okay. So vulnerable groups versus high risk groups, clinical, social, geographical. So this is very important. Health management and information systems, HMIS. Okay, so we have an online software system. So we have an online software system for TB reporting as well as the compliance of treatment. So for TB reporting and compliance of the treatment, just online software system or online portal is known as NICSHE. NICSHE portal. Okay, it is for online TB reporting and compliance of treatment. Then we have something known as 99 dots. So what is dots? Dots means directly observed treatment short course. So what is 99 dots? So dot strategy is government commitment and case detection will be there. Case detection, passive case finding will be there. And standard short course chemotherapy, at least to all confirmed sputum smear positive under proper case management. Regular drug supply of all essential anti-TB will be given. Maintenance monitoring for program, supervision and evaluation will be done. So on opening the foil, there is a toll-free number to which a missed call has to be placed. So in this toll-free number there is will be given, and into this toll-free number a missed call should be placed, and the number is going to be different on every tablet and it ensures compliance. What is MERM container? Medicine Event Reminder Monitoring System. MERM container means Medicine Event Reminder Monitor System. It is a GPS enabled box which detects when the tablets are taken from the container and are informed onto the NICSHE portal. It sounds an alarm when the tablets are not taken, and the same is going to be displayed in the NICSHE dashboard so that follow-up is done. System is to increase compliance again. So prophylaxis of tuberculosis. So coming to the prophylaxis of tuberculosis, drug of choice for prophylaxis is going to be isoniazid 300 mg OD for 6 months. So isoniazid 300 mg OD twice, OD once daily for around 6 months is going to be for prophylaxis. Then TB preventive treatment is for those who cannot afford or do not want to take 6 months of isoniazid. Short TB preventive treatment is only 3 months of weekly rifampicin. Rifampicin or isoniazid. So for drug sensitive TB contact, for MDR TB contact, we give the same thing. Bacteriologically confirmed pulmonary drug resistant TB patient, counsel and screen contact. We should counsel and we should investigate for TB. So we have covered the tuberculosis and National Tuberculosis Elimination Program in detail. So to learn about more topics in community medicine and further other subjects, please do like, share, and subscribe this channel.